Hello, everyone. Welcome to the PAPERI's webinar series. My name is Mariam Youssef, the PAPERI's Education TA and today's moderator. Thank you so much for joining us for our second session on the Introduction to Polygenics course. I'm delighted to introduce our esteemed speaker, Dr. Wafa Rashid. Dr. Rashid is a lecturer at the Faculty of Pharmacy, Ahram Canadian University in Egypt, and the chair and founder of the Pan African BGS Education and Research Initiative, the PAPERI. She specializes in genetic and genomic research with a particular focus on polygenic risk scores and their application in diverse African populations. Dr. Rashid is also the founder of microRNA Childhood Cancer Catalog M3CS, a pioneer initiative aimed at advancing research on microRNA childhood cancer. Her research interests include the identification of genetic variants that contribute to complex diseases and the development of personalized medicine strategies. Dr. Rashid has collaborated with international teams on genomic studies and actively advocates for genetics education and research infrastructure in Africa. Through PAPERI, she leads efforts to enhance polygenic literacy and advocate for policies that support ethical and equitable genomic research across the continent. Please join me in welcoming Dr. Rashid. Please note this session will be recorded. Please mute your microphones. We will now open the floor for questions from our audience. If you have a question, please use the raise your hand button and or just type your question in the chat. Dr. Rashid is going to try to address as many questions as possible within our allotted time from 2 to 3 p.m. Thank you so much. Dr. Rashid, please, the floor is yours.
Thank you, Mariam. Now we can start the question. As I told you, we should end this session at 3 p.m. as we have webinar at 3 p.m. Okay,
Sure,
let's
Doctor.
start. No one. It's good, but what about discussion? This discussion parts. I think there is assignment and there is part optional critical thinking question for discussion. Who answered this? Who tried to answer this? Okay. TV, so I think you are from Gambia, the Gambia. Okay, let's go. Yeah, start.
Yes, Doc, I'm from the Gambia.
Uh-huh. Yes, I know you. Yeah. Okay.
Yes, I want you to make more elaboration on the bell curve of the height which you have shown in your presentation. I saw at the two rare and you say rare. How, when does that rare actually? What does that mean in the bell curve?
Um, Again, please repeat your question.
I mean, in your presentation,
Yes.
you draw a bell curve for the height as a polygenic. So at the two extreme end, there is a rare genotype whatsoever. So can you
There,
kindly make an elaboration on that rare end of the bell curve?
you mean the Pearl curve that I used to discuss or present the, the quantitative nature of polygenic traits. Yes?
Exactly, yeah.
Yes. So what's your question?
So the beginning, the two end of the bell curve.
Yes, there
Yes,
most of people due to the polygenic effect. I told you that polygenes effect is additive, leading to most of people, uh, additive effect leading to the final phenotype, putting most of people in the average region or the average uh, uh, here in the bell curve. Just a moment, I will share with you the curve. I can share my screen. Oh, yeah. Okay. This one. You can see my screen?
Yes, ma'am.
Yes. Okay. Most people here, if we say this is phenotype for height, between 60 to 80 feet. The average here, also people have the average or median version of the phenotype here is height. But for rare cases, I mean, if there is epistasis or epistasis means gene interaction. Uh, Polygenes is a set of genes affecting height. If one of these genes or two or three affected by another gene in another place, the phenotype that sorry the this it's called gene interaction or epistasis. What will happen? Affecting this gene in the polygene set, leading to mask or alter its effect. So leading to shift from the average to be less than 70 or more than 70, away from the average. You understand me? Is it clear?
Yes, I do.
So yes, most of people here in the average. For example, if we have average 70, will be 70. But due to gene interaction or gene environment interaction, there will be a shift from the average to be lower than the average or higher than the average in the extreme cases. Nice question. Thank you.
So just a follow up to that.
Okay.
So this the rare cases, is there any way that if there is an environmental influence that can shift this rare case to on average and the average to rare case?
Is there any environmental effect that will affect this?
I mean, is there any possibility that if maybe at a point in time the environment doesn't favor those people at the average at the center of the bell curve,
Oh,
and then it shifts the direction towards the rare cases, and the people at
yes.
the rare cases to move into the average cases. Is there any way
Again,
that is that possible?
reversibility. You mean it's a reversible case? You mean that shifted from the average, then back again?
Yes, I mean shifting of the cases from rare case to common case. Is it possible? Probably due to environmental effect.
Ah, to be um uh it's yes, I think so. Decrease, I think, but not for height. But let me remind you, you are a member in PAPERI community, right? In the WhatsApp group.
Yes, I
Do you remember that I sent not the previous week, this week, 2 weeks ago, I sent a paper, recently published paper about one carbon metabolism. In which I told you that one carbon metabolism diet may affect Alzheimer, like methionine or folate, vitamin B12. Uh, um, uh, the uptake of this diet leading to decrease the risk of Alzheimer. Even if there is a high risk, if the patient or the individual at high risk of Alzheimer, if he or the individual taking a high amount of one carbon metabolism diet, it will decrease its risk from the from progression to be affected or to diagnosed as Alzheimer with Alzheimer. I mean, yes, environmental effect can affect decrease if we act in the prevention, if we detected the patient or the individual with polygenic risk score, that he in is in the high risk category, we can use preventive tools, environmental and so on, lifestyle, to decrease his risk. Like I said, in case of Alzheimer, uptake a large amount of one carbon metabolism diet decrease his risk, although he has uh, high risk polygenic risk score.
Yeah, I think I get the point.
Okay.
I was trying to relate it to, let's say, for instance, some pathogens when they develop resistance. At a point in time, there may be a positive selection whereby the resistant strain will just, skew towards the uh, um taking the higher population, while the susceptible one will just clear out because of the environmental nature. But once the environment is restored again, the resistant one will clear out and the susceptible one will come up. So I was trying to correlate whether the same thing happens here also when you come in terms of polygenetic the score, whether in the height or this other one, you could have done the same thing.
The main point is the research in this phenotype, Alzheimer, height, whatever diabetes. You should do extensive research to see the environmental effect that may act in prevention as a preventive tool you can use to modify if there is a high risk of this individual, how to decrease his risk using environmental tools. Okay.
Well understood. Thank you, doctor.
Mhm. Okay, next. I think Kennedy and Nickenberg. Kennedy.
Okay. Yes. Thank you very much. My name is Simonike Kennedy Q. I'm from Nigeria. And first of all, I want to appreciate the moderator and the facilitators of this course. It's been very, very insightful, and I am learning a lot. So my question is towards the techniques used in studying the polygenic scores. First of the GWAS, that's the genome-wide association study. And my question is, I'm trying to understand how it actually works. Is it that we get, first of all, we scan the genome of individuals in the population, right? Then maybe for a particular trait, we scan the genome to ascertain the loci of the loci of the different genetic variants that contribute towards the expression of that trait. Then maybe put it in a catalog. Then after that, scan individuals of interest to check if they exhibit or have same um, genetic variants. So my question is, but do they have to have all of the genetic variants of maybe the one in the catalog to then ascertain their risk towards exhibiting um, the traits of interest? If not, to what degree do we now say, okay, this person has the risk of exhibiting such traits or phenotype? Same with the polygenic risk scores, where we aggregate the effects. So do we apportion scores to each of the variants or the alleles that contribute towards the expression of that particular trait? If so, how do we do that? And at what point or to
Your
what degree
question,
do we not take that?
let me to what degree or what which point what?
Sorry, I didn't get that.
We start with GWAS, genome-wide association study, comparing two groups, one with and one the other group without the phenotype. Okay, right?
Okay.
Yes. And we will, from this technique, we will obtain significant variants that affecting the phenotype, right?
Okay.
Yes. After that, we will use these variants to calculate polygenic risk score. To calculate for certain populations, especially if we run VWATs for certain population, African or European. So we will complete to see to calculate polygenic risk score for this population. So what's your question? We here calculate polygenic risk score and we obtained it. What's your question?
My question is particularly how you score the I don't okay, do we know, for instance, do we know the degree to
Mhm.
which each of the polygenes has an effect in the overall phenotype? Do we Is that the first thing to do, or is it already something that we already
You
follow this?
uh, after we calculating polygenic risk score, how we categorize people to be at high risk, low risk in the average, right? This is
Exactly.
this is your question. Yes, this is what David will discuss with you in uh, lecture 3 and 4. Uh, Calculation. Then we draw like it's not a curve, it's a plot. 40 to 60 is the average. Over 60 considered to be at high risk. Less than 40 is considered to be in the low risk. This essentially can David he discussed this with you. He will tell you and show you that the plots, so you can understand when you see this in the publication or anywhere, you can understand how you understand or explain these plots. But let me discuss again or explain this. First, you will run GWAS in certain population or in mixed, there is no problem. But after that, you will obtain specific variants, significant variants that affecting this phenotype. After that, you will calculate polygenic risk score. Calculation of polygenic risk score is the summation of each variant multiplied by its weight. The summation of this leading to polygenic risk score will presented in a plot from 0 to 100%, 40 to 60% is the average. Above will be people at high risk. Below 40, above 60, um, but not above 60, means in 10% in the top. I mean, between 90 to 100%. They high risk, very high risk individuals. And low risk below 40. 40 to 60, usually we categorize these individuals as average, in the average. Is this clear? Yes, can you? Is this clear?
Yes. Yeah. Thank you very much.
You should understand genome-wide association study and the concept, how to calculate polygenic risk score, the how to step by step of this will be illustrated and discussed in detail by David in the next lecture. Okay, next, Nick and Phil. Okay,
Yes,
okay,
good
go on.
afternoon.
Good afternoon,
I'm Timbeng Desmond Akumto from Cameroon.
Cameron. Hi.
Yes, I'm very grateful to attend the meeting of today, and I want to appreciate the entire team for the great initiative. I've learned a lot from the previous lectures and the courses. I have a couple of questions concerning your presentation that
Yeah.
you sent to the link. While reading an article, I came across the concept of phenotypic plasticity, which is the ability of organisms to change their behavior, their morphology, and their physiology in order to adapt to environmental changes. I don't know whether this is different from environmental adaptability. I want to find out whether there is a difference between phenotypic plasticity and environmental adaptability.
I discussed this in my presentation, phenotypic adaptability.
it was one of the resources you sent. I tried to check some of them and I came across these various concepts: phenotypic plasticity and environmental adaptability. I don't know
Okay.
whether they are the same or they are different.
Ah, okay. Let me check this with you, but in the resources,
Yes, in one of the resources you sent.
okay, I will check it after and see, but this is not our issue regarding polygenic tree.
Okay. My next question has to do with epistasis. Is it a natural or an induced phenomenon, that is gene-gene interaction? Is it natural, spontaneous, or induced?
Natural or induced? What do you
Yes.
think?
Is
When
it,
you see, uh-huh,
I mean, epistasis, gene-gene interaction, one gene
gene
influencing or
epistasis.
modifying another gene, yes. Does that
Yes.
occur naturally, spontaneously, or it is induced?
Uh, you can say it's induced, or it can be induced and be both of them. You hear me?
No, I can't get you clearly. There is a breach of connection.
You can't hear me now?
Yes, I can get you now clearly.
Okay, your question regarding epistasis,
Yes.
right?
Yes.
You mean it's natural or induced, right? This
Yes.
is your
Yes.
question. Okay, this is phenomena. As I told you, it's affect gene-gene interaction. Gene in place in certain locus is affected in another locus. It may be natural
Okay.
or induced. Natural
Okay.
occurs naturally in populations. Okay, as a result
Yes.
of, you can say it's evolution. But when it's induced in lab by scientists, by means manipulation. You can say it's manipulation. Induced epistasis is a manipulation induced in the lab by scientists. So it's natural or it's induced.
Okay.
You get my point?
Yes. So it can occur naturally or it can be induced.
Natural as a result of evolution. Evolution, no problem. Induced, you hear me?
Yes, I'm getting you.
Ah, induced in lab can induce epistatic interaction by manipulating genes.
Okay.
Genetic engineering, mutation, breeding, any other techniques used, it's under manipulation, manipulating genes.
Okay. Okay.
Okay.
Yes. I have another question which has to do with genetic architecture. Please, can you explain the concepts of genetic architecture? What does it mean?
What I mean by genetic architecture,
Yes.
so let me say, what is polygenic traits? The concept of polygenic trait. What does this mean? Polygenic trait, what does this mean in general?
Polygenic traits. It means
Uh,
several genes
yes, a
are
set of genes.
interacting. Yes, interacting to add up to an outcome or a phenotype. They all contribute to an
Interaction,
outcome.
contributing in
Yes.
an additive. Yes. Okay. And this is small effect leading to the final phenotype.
Effect. Mm-hmm.
So when I wanted to know the genetic architecture of polygenic trait, I mean what lead to
Okay.
this polygenic trait. It is a result of additive effect of the polygenic trait maybe by the effect of epistasis, gene-gene interaction, not only genes in this set, but other gene in another place, locus, may alter or mask one of the genes in this set, the polygenes. In addition to the third option, or not third option, the third effect can affect the genetic architecture of polygenic trait is gene environment interaction. So this is the genetic architecture of polygenic trait. You understand completely what's meant by polygenic traits, but to understand well, it's not only these genes, but may be affected by other genes in gene-gene interaction epistasis or gene environment interaction. Is it clear?
Yes, it's clear. Thank you. The last question, coming back to the dumbbell shape that was illustrated initially, where you have most people having the average or the medium version of the trait or the phenotype.
Yes.
Yes. Why is it that most people, majority of people in the population have the medium version of the phenotype? Why is it so that majority of individuals in the population have the medium or the average version of a phenotype?
Because it is the normal effect of the additive effect of polygenes affecting the final phenotype, height, weight, skin color. But if there is a gene-gene interaction or gene environment interaction of one of these genes affecting the final phenotype, lead to the shift from the average.
Okay.
You understand? There will be a shift from the average, right or left, below or above the average. So increasing risk or decreasing risk. But most of people normally in the average. Okay.
Okay.
Thank you.
Thank you for your responses. Thank you.
Thank you. OL. Making pink. I think you asked your question. Is there a question in the chat? Is there any question? It's done. Hey, people who answered the optional questions. Who tried to answer the optional questions? You hear me? Excuse me, you hear me?
Yes, we are hearing you. Yes.
Yes, ma'am.
Okay.
It's not clear.
Tried to answer?
Your voice is not clear.
My voice is not clear. Yes, we
No,
can.
it's not clear at all.
I think there is a problem in your computer. So, as most of participants actually can hear me. Okay, who
We can hear you,
to
but it usually breaks. Your voice is
Okay.
breaking. So that's the issue. We can hear you, but it breaks. So we can't get the full or accurate or whatever you're trying to pass across.
Okay. Who tried to answer the discussion questions? So, optional critical thinking question is are clear. Genetic modification can influence the expression of polygenic traits. The first question, and the second one, ethical consideration of using polygenic risk score to predictive testing in newborns. And the third one regarding, what's the moment? regarding gene-environment interaction are complex and hard to quantify. Propose a research study design that would allow scientists to measure gene-environment interaction for a polygenic trait like diabetes. Is there anyone who tried to solve these questions? No one. Okay, Rachel, you
Yes,
tried or you have a question?
I tried. Good morning.
Yes. Yeah, good morning.
My name is
Okay.
Rachel Osage. Thank you very much for this opportunity to ask questions. I'm a student in Canada, so we are morning time, so please pardon me if I'm not too audible. Um, Concerning the part on critical reasoning or the three questions. Number two, I can provide a little insight on that. Ethical concerns associated with the use of PRS in newborns. Um, so for me, the way I chose to talk about it, I tried to put them into headings based on the fact that newborns, one of the issues with all of these studies generally is the issue of informed consent.
Yes.
So newborns do not have the ability to provide consent to those things.
Excellent. You are right.
So,
Yes.
it will require parental consent where indicated. So, for me, I think that PRS in newborns should be absolutely, would I say, there's a word I'm trying to use, should be absolutely used only where there is indication for it and there's a medical indication for it. So there should be strict regulations as regarding the use of polygenic risk scores. In addition to this, one other issue apart from informed consent is the issue of misuse. Being a relatively recent research area, there's a lot of misinterpretation that has been associated with the results that come from PRS. For instance, what does a PRS score of 4 mean to a regular clinician? In essence, you have to be trained in these fields to be able to communicate the right interpretation to these scores to the parents so that you do not instigate fears in the minds of the parents as whatever regarding whatever condition that has made them to present to the clinicians. So that's my second point on misinterpretation of results. And then my third point is regarding discrimination or stigmatization. There have been issues of in cases of adults now where you have limitations, maybe you have a condition, employers may use that as one form of criteria to knock you off such rules. So I just largely grouped my concerns into informed consent, misuse, misinterpretation of results, as well as the discrimination of or stigmatization of the patient. I don't know if that was able to
Yes.
answer all the questions.
Excellent. Excellent. Well done. I think you submitted the assignment yesterday.
Yes, I did. Yes, I did. Yes.
Yes, and Ziad from Egypt. Both of you submitted.
Yes,
Yes, Ziad. Thank you
yes,
very much.
exactly. I
Yes.
submitted on Wednesday.
Yes, and you tried these questions. Thank you very much, Ziad and Rachel. Uh, you covered the points of restrictions. Yes, there is a restriction due to informed consent, discrimination, and stigmatization. But yes, in some cases, there is no restriction. Well done. Thank you, Rachel.
Thank
Thank
you
you.
very much. Thank you.
Okay.
I
Do you
had a
have any?
follow-up question
Uh-huh.
regarding the same point of ethical considerations and newborn polygenic risk score calculation. So
Yes.
we know that polygenic risk scores indicate an increased or decreased susceptibility to a certain disease,
Yes.
and some of those may not have possible therapeutic intervention. And so, if we apply a screening program for polygenic risk scores, it may just lead to increased psychological harm to the newborn early on and affected the relationship between the parents and their children. So I wanted to understand your point of view regarding the ethical implications of this point.
The ethical implication regarding psychological impact?
Yes, would it be indicated to apply a screening program based on polygenic risk scores if there is no pronounced therapeutic or preventive strategy for this certain disorder?
If there is no preventive program, so why we apply? So why we try to do genetic testing for the newborn? So the next step is not actually present. I mean, if we we have a complete plan, we do this. If we find certain risk, we will go through this way. If not, we there is no action. I mean, uh, as you said, screening program should be put in place in upfront, so we can follow when we apply genetic testing. You understand me?
Yes, I understand.
Okay, so yes, we can run genetic testing in certain situations where PRS can calculating PRS can lead to early intervention and preventive health care, improving long-term outcomes. If these outcomes are not in place or prepared in advance, so there is no meaning to do genetic testing for newborns. It will cause discrimination, psychological impact, and there's concern regarding privacy, and so it's not it's not it's not a good um, a good practice. Missing something. We should plan if we want to do genetic testing, calculating PRS for newborns. We should know the algorithm. If we find certain if we find this newborn at certain high risk, we should go through this. We have certain plan to decrease, to improve healthcare outcomes, long-term outcomes, put sorry, make early intervention and so on. If it's not in place, there's no meaning. It's not advised to do genetic testing for newborns. Is this
Even
true?
if it could lead to preventive actions for the recurrence of the disorder in future pregnancies?
If it's what?
So if we can use a polygenic risk score to identify a higher occurrence of a certain disease in a family,
If you can use polygenic risk score, you should have a plan how to apply. So it's a complete program plan. You understand me? You will do this.
Yes, I understand your point, but I mean, if we are able to diagnose a disease, even if no further preventive or therapeutic options are available for this child, it could still help us to choose a healthy newborn through IVF, for example, in future pregnancies and prevent the recurrence of the same disorder in this family.
Genetic
So,
testing regarding you will make genetic testing for newborns for specific diseases, right? It's
yes,
not absolute for certain diseases. So you will put preventive measures, interventions, long-term outcomes, how to improve it. You have tools how to affect this high risk to decrease, to decrease the risk and improve the long-term outcomes. If you don't, so why? Why you apply BRS for this patient? My question. when you don't know what will be the next step to improve long-term outcomes of these patients, or there is no early intervention or preventive measures. Why you do calculate polygenic risk score for them? What I mean is we should prepare a complete plan. We will do genetic testing for newborn for specific diseases, and we know if we obtain or we found if we find certain newborn at certain high risk for this disease, we have a plan to put or algorithm like yes, so we will go through this follow up lifestyle specific measures to improve long term outcomes, to decrease to try to modify his risk as an early intervention. Okay. Is this the answer? Is this the answer of your question?
Yes, thank you.
We have 15 minutes. The last question by Oscar.
Thank you very much for this opportunity. I also want to say that there's a risk of misinterpretation for the newborn. I think some people take the scores to mean you have a definite risk of something happening, whereas from this course, we are learning that there is an interaction between the environment and the genetic risk. So this should only be put in place where there is appropriate genetic counselors in place, and where there is follow-up of the family involved to ensure that they do not think it is a definite risk, that they can do something about it. So that's my comment regarding ethical considerations for newborn testing using PRS. Thank you.
Thank you. Okay, now Mariam. Okay. Mariam?
Yes, doctor, we have one last question in the chat box.
Oh, okay.
For Dr. Shaw. Yeah, one last one.
Why do we calculate polygenic risk score? Why? Okay, let's. When you search for this question on the internet, what did you find? Why we do this? You are here, Dr. Opilo. Dr. Opilo? Yes, you are here. May you unmute your mic? Opilo? You can't hear me?
Dr. Shaw?
Hello. Hello, I
Yes.
can hear you. Your line is breaking.
Why you ask this question? I think I answered this in the lecture, the significance of studying polygenic traits or calculating polygenic traits for disease prediction, for personalized medicine, and for public health. So the answer is clear in the lecture. So what do you mean by your question? Something
it was not so clear. That was what I asked. It was not so clear to me.
Not so clear?
Yes.
So why there is a confusion? What did you understand? Did you do search about polygenic trait, polygenic risk score, and how you calculate it? Why do you calculate it?
I've not done such on it. I've not
Why?
done such on it.
Why? You should let's agree that you are postgraduate. When I was teaching assistant, senior teaching assistant in a course affiliated to Harvard THSN School of Public Health, they advised us not to answer questions, but guide course participants to do search, to give them resources to search for questions, and then come to meet us in the office hours and discuss with them what they found. And our discussion, I can clarify points, correct any misunderstanding. So you should, as Rachel done and Ziad, for example, answer questions, critical thinking question, and come to me, discussing it with me. So our discussion, he can understand me. So when I answer his question, I correct or confirm certain point he actually understand from his search. So please don't ask a question as you are a postgraduate. Try to be independent. Try to answer question yourself. Search for it. Then come back. This your search will decrease the gap between you and the instructor or the lecturer. So when you ask, you understand. So you will be near from his point. You can understand what terms he will say to you. But when you didn't do search for the question, when I answer, you will say, yes, thank you very much. But I don't need debate. I need points is not are not clear for you. You understand me? Is it clear?
Yeah,
So please
actually,
do search.
actually, the
Yes, Opilo, please do search about this question, and we can complete in week 2 WhatsApp group. What did you find? I am with you. So what you find, you can discuss with me and with the group. So you can, I will be sure that you get the correct point or significance why we calculate polygenic response. This is the main issue of our course. So please do search first. So decrease the gap between me and you. Then
okay,
our discussion, yes, you will use the same terms. You understand me. When I say certain term, you will get it.
okay.
Is it clear?
Thank you.
But
Okay,
thank you very much for you and everyone who tried to and attend my session. But again, try to be independent, to search for your question, to decrease the gap, then ask your question to be on the same level and understand when you talk with the instructor or the lecturer. Okay,
thank you.
thank you. Mariam?
Yes, doctor. Thank you so much, Dr. Rashid, for answering the questions and for your excellent presentation. It was a pleasure to have you with us. Before we wrap up, we would love to capture a group photo. Please turn on your cameras if you're comfortable so we can get everyone in the shot. And right after we take the photo, please make sure you complete the post-lecture survey that I'm going to post in the chat box. It's important for tracking your attendance. Thank you so much for cooperation. Thank you again for attending, and I hope you have a wonderful day. Please note that there will be a webinar that starts at exactly 3 p.m., 7 minutes from now. We have a Google Meet, a link that was sent to your groups. We will make sure to send it again.
So please open your camera.
Yep.
If you have any question, please send on the week 2 WhatsApp group, okay?
Dr. Salami, no worries. I'm going to send the recording, or Dr. Wafa is going to send the recording right away. So any part that you might have missed, you are going to see it in the recording.
All right. Thank you very much.
You're welcome. Okay.
Yeah,
So
sorry. Okay,
yeah.
so yeah, sorry, Miriam. So I after we took the pictures in the last class, I didn't know you dropped the attendance in the chat box. So I was told to send an email. So maybe I would copy you in the email to Dr. Wafa. Just take note of that, please. Thank you.
Okay, sure. Yeah, no worries.
Please open your camera. Ziad, Salma, Tumai, Karine, Sarah. Everyone, please open your camera to take the photo.
Okay. So I'm taking the picture right now.
Yeah.
Okay, hold on. Thank you so much for
Thank you.
attending. Thank you, Dr. Wafa. Okay,
Thank you.
so please make sure you fill the questionnaire in the chat box. Like,